Good morning.
Good morning.
So we'll just wait a second. Group. All right, I think, let's see. All right, I think we have enough to get going here. Good morning. So again, we're going to do some relatively basic concepts since we're at the start of the year. So moving on, each week I'll try to cover a drug for the next couple of weeks, just until we are, have gone through everybody, or most of the major ones at least. Oops, sorry. Okay, so let's talk about calcium channel blockers. And when we're talking about them, we're speaking mostly about verapamil and diltiazem. And both of them work to slow calcium channel cells of the SA and the AV node. And they depress automaticity. They also decrease conduction velocity, excuse me, and they increase refractoriness in the AV and sinus nodes. And for this reason, they are particularly good in treating AV reciprocating tachycardias of the AV node, like ORT. But they can also be used as a rate controlling drug as well in primary atrial arrhythmias. Generally, they don't have any direct electrophysiologic effect on the atrial or the ventricular myocardium, except slow channels may be important to myocardial early after depolarization, which may play a role in certain types of arrhythmias, with the most common one being Bell-Hassen's tachycardia, which some of you may recall is a form of left ventricular outflow VT, typically coming from a specific area where there's enhanced automaticity. And because of this, this may explain why it is that verapamil is a particularly good agent for the treatment of Bell-Hassen's. Both verapamil and diltiazem are well absorbed from the gut, but are only 30 to 40% bioavailable after the first pass metabolism. And very little is left when it's excreted in the urine. The half-life of verapamil is 5 to 12 hours, and diltiazem has a half-life of 3.5 hours. And both of these agents can be given IV. I think we've talked about this in the past, that in the olden days, before the advent of adenosine, which really is only since the late 80s in clinical use, verapamil was the most commonly used agent to terminate SVT in patients who were, in the emergency room, for example. But you have to be careful, particularly with verapamil, because verapamil can be very hemodynamically embarrassing. It can cause severe hypotension and can even cause cardiovascular collapse. So you have to be very careful to infuse or give verapamil very, very slowly. And that can be challenging because it happens to come in an IV variety in a very concentrated manner. So the nurse helping you has to make sure to dilute the verapamil very extensively so that it is not given too rapidly. So again, the side effects are hypotension, particularly with fast pushes, can depress myocardial function chronically. The most common complaint people have on verapamil or diltiazem is constipation. It can cause dizziness, nausea, or headache. And of course, because of its effect on the AV node, it could cause heart block, particularly though and almost exclusively in patients who already have pre-existent AV block. So if you're starting this agent in someone who already has substantial first-degree heart block, one would have to be very careful and monitor that patient closely. Couple of interactions that are important. Verapamil increases cyclo levels, theophylline levels, and carbamazepine levels. And diltiazem does the same, but also increases digoxin levels. And this is extremely important, that this is contraindicated. The use of these agents are contraindicated in WPW because they may enhance accessory pathway conduction and enhance the possibility of life-threatening arrhythmia. So you never want to give a calcium channel blocker to anybody who has WPW because of the chance that you can enhance the risk for sudden cardiac death. That includes, by the way, if somebody presents with rapidly conducted AFib. If you were to give somebody verapamil, it could easily enhance conduction and turn that AFib into VFib. So please always never use verapamil or diltiazem in the setting of WPW. Digoxin is similarly contraindicated, but we've discussed in prior lectures that digoxin is used by some cardiologists still in the newborn period for the treatment of SVT in the setting of WPW. There are some cardiologists who believe that the risk is so small, the risk of rapidly conducted pre-excited AFib so small that it's reasonable to use digoxin in that age range. But I've explained to you, I don't generally use it for that purpose, just on the general theory that why would I take that risk when there are other agents? But I think it would be fair to say that it is not wrong to use digoxin in the newborn with WPW, but I do not generally use it, and I would probably recommend that you avoid it since there are other agents. Okay, that's our drug of the week, or drug class of the week. Let's move on now to a tracing. So this is a 4-week-old, but it could just as well be a 4-day-old. And since it's a young infant, and since we happen to have the opportunity to have a neonatologist on the line, I'm going to ask Dr. Zawani what rhythm he believes this is and how he would manage it.
I think we have a sinus rhythm with like a B wave in lead 2 before each QRS. But the QRS is very tall, so
Well, before we go any further, let me interject. Is there truly a P wave before every QRS?
So I've seen in the lead 2, the first, yeah, it disappears after the third one.
Mm-hmm. Look in lead 1 or lead AVF. Do you really see an obvious P wave that precedes each QRS?
Yes, it's not there.
Also look in V3. I think it's even more obvious that there is not a P wave before each QRS. And I think you made an interesting and important observation regarding P waves and their relationship to the QRS. That I think what you were, I don't want to put words in your mouth, Tarek, but you were referring to this possibly being a P wave and then not seeing it later. Is that what you were saying earlier?
Yes.
Yeah, so how would you describe the relationship between the P waves and the QRSs in this tracing?
Dissociated.
Dissociated, well stated. That's exactly how I would say it. So I don't want to interject anymore. So what do you think this is? Okay, so I guess
Yeah.
the first question is this a wide QRS or a narrow QRS for let's say it's a 4-day-old instead of a 4-week-old, but it's the same, it would be the same.
Yeah, it's a narrow QRS.
Well, it is narrow, but I think it's actually a little wide for a newborn, right? It's definitely wider than one box on the EKG. I grant you that this is a lousy tracing because I think this is a faxed copy. But generally speaking, for a newborn, the QRS should really be less than 40 milliseconds in duration. So it's a little wide, but I certainly agree with you that it isn't very wide. And what do you make of the heart rate? Is that a reasonable heart rate for a 4-day-old?
No, the heart rate is low for a.
It's low, but it's not. It's not like dangerously low, right? It's about. It's in other words, if you saw a baby with a heart rate of 110 in the NICU, you would not start doing a big workup over this.
Yeah.
So basically, and the other interesting thing is that, what do you think about the QRS axis?
So there is it's a left axis.
Right. And is that a normal axis?
No, for a newborn, no.
No, it should be more rightward, right?
Rightward, yeah.
Now, if this were like a 4-year-old, we would say this axis is pretty reasonable, right? But for a 4-day-old or a 4-week-old, this axis is a little too leftward. So what this is actually an accelerated ventricular rhythm, where there is ventriculoatrial dissociation. And for whatever reason, the ventricular rate is faster than the atrial rate, or at least similar to the atrial rate. Why don't we just move the slide? So generally speaking, accelerated ventricular rhythm in the newborn is a benign condition, and it is rare that we need to treat it. And you usually see it in patients who have a structurally normal heart, though it is rarely seen in patients with congenital heart disease. And generally, it's a monomorphic acceleration faster than the underlying sinus rate. And according to some authorities, if the rate is over 150, instead of calling it an accelerated ventricular rhythm, we would maybe call it ventricular tachycardia. I think the same could be said if at any time a ventricular rhythm was causing hemodynamic embarrassment, probably we would also call that VT as well. Usually they have a left bundle branch morphology, which this one does, right? It's upright in V6 and lead 1, mostly down in V1. The natural history of these is that they generally resolve. This reference that I found, which is an old paper by Jim Perry, he said that by age 3 to 5, nearly 100% resolve. That's true, but it's probably even true that you could say that by age 12 months, nearly 100% resolve. And generally, when we see a patient who has this arrhythmia, we would recommend performing an echocardiogram to assess the function, whether there's dilation of the heart, and the anatomy. Now, why would the function and the presence of dilation be an important thing to assess, Tarek?
Because you want to make sure that the patient has a normal function, because in case the function is very decreased, then you have to think about like options for treatment for a dilated cardiomyopathy in setting of heart failure.
No, that's true. But why would it generally be? Why could this rhythm cause dilation or dysfunction?
I think with time, if the rhythm is really accelerated, it just impairs the function of the heart.
That's right. It essentially causes a tachycardia-induced cardiomyopathy. So really, you would want to do the echo to make sure that, now we would not expect that at a heart rate of 110 that we would see a cardiomyopathy picture from someone with an accelerated ventricular rhythm. However, if you saw dilation or dysfunction, you might think that maybe that would be a sign that perhaps the heart rate is substantially higher than that EKG a lot of the time. And that would be really one of the most important indications to treat this patient. Obviously, you would want to get a good family history, make sure there's not a history of cardiogenetic problems, channelopathies, particularly things like VT, like a long QT syndrome or CPVT. But again, in those conditions, we would not normally see a monomorphic ventricular tachycardia. Those are generally characterized by polymorphic VT. In fact, the classic arrhythmia of long QT syndrome, which, as you know, is torsade de pointe, is defined as being a polymorphic ventricular tachycardia in the setting of a long QT interval. So the fact that the rhythm is so monomorphic would generally not be consistent with most channelopathies. But you would certainly want to try to find a sinus ECG in order to measure the QT interval. But usually what one would do for this is, now there are some cardiologists who just don't like to look at this rhythm and want to try to treat it. And it's not necessarily wrong, but I think the problem with trying to treat this in the absence of any obvious evidence that it's causing a problem for the baby is that often it's hard to treat. And we would normally start with a beta blocker or something like that, but it is not uncommon that one cannot easily control this rhythm. And that usually what happens, thankfully, is that it generally decelerates until finally the sinus rate is faster than this rhythm and the baby no longer has accelerated ventricular rhythm. So one would follow this very closely as an outpatient, monitoring function and dilation as sort of indirect markers of resolution, but also, of course, doing something like a Holter monitor or a Zio patch or a Barty device to sort of quantify how much tachycardia the patient is having and to sort of monitor the progress of this. Okay. All right. This is a child who is in the ICU and is, on the monitor and is being monitored, obviously. And you are the good fellow, Dr. Candon, and you are doing your telemetry rounds in the afternoon on a weekend, and you notice this, where the red arrow is pointing. And so, and this is an infant, let's say, who had congenital heart surgery, because that is what this infant was. And all of a sudden you see that. And so I'm going to ask you, Dr. Condon, what you think you're looking at there, because this is an example, one of many that we'll go over this year, where I think looking at the heart rate trend can be very illuminating. So what do you think, Tulsi, is going on here?
Hi. The first thing that comes to mind is wondering whether the leads are attached properly, just to make
And
sure.
what are you, what particular problem are you invoking with the leads not being properly attached that would cause that finding? I'm referring, of course, to this area here.
What finding on the telemetry? Like asystole.
Okay, so but actually the heart rate line is at about 150, right? But
Gotcha.
I agree that it is conceivable that some form of artifact or absence. I mean, normally artifact would cause, wild variations in the heart rate on the heart rate trend, but I will give you partial credit for that. But if you think of anything else that might explain, so we'll give you partial credit for that answer. Are there any other phenomena that could potentially explain that finding on the right-hand side of the heart rate trend?
So basically their heart rate is at 150 or whatever that is, but there's no variability in it.
That's
Is that what
correct.
you mean?
That's a very astute observation. Is there, to the left of the arrow, is there variability?
Hmm. Yes.
Yes, there's quite a bit. And to the right of the arrow, not so much, right?
Hmm.
Like zero variability, right?
Right.
Like somebody took a ruler and drew a red line, right?
Right.
So is there any good explanation for why it might look like that?
Mm,
Okay, I'm going
I'm
to
not sure.
phone a friend, and I'm going to ask Dr. Grace Kong, the chief fellow, co-chief fellow, if she has any insights into this. Even though she's going to be a non-invasive imaging attendant, we're going to remember that she'll also have to round in ICUs. So what do you think is going on there, Grace?
That's right. So we are in the ICU, so pacing is a possibility, but our variability rate goes higher than our pacing rate. So that's a possibility, but I also think that this could be flutter, something that would cause a very regular heart rate.
Okay,
or some.
Go ahead. I'm sorry to interrupt you.
No, it's okay.
I have a problem. I have to I have to shut up.
No, please don't. Or any other reentrant tachycardia that is not at a very fast rate, so not an SVT other than flutter, but like a ventricular reentrant tachycardia, even possibly, or. Mhm.
Okay, so I would agree with you that this is clearly something very, very regular. And so Grace is essentially telling us that when a person is in a reentrant arrhythmia, the R-to-R interval is generally relatively fixed, and so that might explain it. And the other option you offered was pacing. And the answer is that this is actually pacing. Now, you astutely wondered how it was that we could pace at a rate of 150 when the heart rate prior to the 150 was actually higher. But this is actually a patient who had junctional ectopic tachycardia, received a bolus of another bolus of procainamide. The heart rate appropriately fell, and then the physician started to atrially pace the patient. And so the point I wanted to make is that when you see a line that looks like that is so profoundly straight, that looks like literally like a ruler was used to draw it, that is not generally what it looks like when you're in a reentrant arrhythmia or in really any physiological finding that can be seen in human beings. That has to be an electronic pacemaker. So when you see a line like that on the heart rate trend, and we see this also, by the way, in patients who have Holters or Zeos and have pacemakers, that when they are asleep, you will see lines like this when they're asleep, because when they're asleep, their sinus rate may fall to a point where they're at the lower rate of the pacemaker, and then their heart rate trend looks like that as well, although at a much lower rate, usually. Whatever the lower rate was set at. If it was a baby, that might be 90 or 100, but in an adult patient, it might be in the range of 50 or 60. So this is an example of electronic pacing when you see such a straight line like this. So you should sort of, photograph that in your memory. When you see a line like that on a heart rate trend, the chances are very high that the patient is being electronically paced. Okay. All right. This is an 8-year-old who is in your office complaining of chest pain, and Dr. Babia is the physician seeing this patient. What is is there an abnormality or not on this tracing, and how would you go about evaluating this patient?
Good morning.
Good morning.
So I would say that the heart rate is about 100. I'm looking for P waves before HQRS, and I So it looks like that. Yeah, I don't think that there are P waves before each QRS. Unless those, yeah, that's too far. So it doesn't look like it's a sinus rhythm.
I don't know if I agree with that statement.
Now the the axis is negative in 1, positive in AVF. So it's a right axis in an 8-year-old, which is kind of abnormal.
Mhm.
And then the QT, yes, and those small blips at the end of the T waves.
So is this a sinus rhythm or is this not sinus rhythm? What are those?
So if those blips are P waves, then it will be a sinus rhythm with a very long PR, and it will be a first degree block.
Now I will agree this isn't the clearest example because in lead 1 the P wave is very obscured, but this is sinus rhythm.
So then with such a long PR, that is definitely a first degree heart block.
Okay, so and I agree with you, the axis is a little abnormal, although, you know, so what would you do? How would you, so you see this patient in the office, they're complaining of chest pain, you can reproduce it, but you have this ECG. So how would you evaluate this, Sergey?
So I would think of any type of possible endocarditis or myocarditis, maybe.
Okay, how would you
So
evaluate that?
I will check the inflammatory markers. I will do an echo. And then things like hypothyroidism that could have caused this as well. So I would check the thyroid function tests.
Mhm.
Um,
Anything else?
Lyme disease.
Right, this could be Lyme disease if they happen to have been in Lyme, Connecticut, which is not unusual in New York City. The patients on a weekend may go visiting somewhere and get a tick bite. So yeah, so you would do all of those things. Anything else you would do in assessing this? So I agree with all of those decisions. Also in COVID time, right? We know
Right.
that there are a number of reports now of children with COVID who develop first degree or even higher grades of block, at least transiently. So probably would do a COVID test. Although, again, other than chest pain, the patient is asymptomatic. So it's unlikely that it's any of those things, but you would probably do all of that. And is there any other aspect of assessment? So let's just say for the sake of discussion, as is usually the case, the echocardiogram is normal. The inflammatory markers are all normal. Is there anything else you would do in assessing this patient?
I guess Holter, some kind of monitoring for
That's
a
right.
few days.
Right. Why would you do?
Right, because I want to see if this is just the first degree block or it intermittently is a more advanced level of a block.
That's exactly right. So you don't really know if the patient just has, first degree block or if there are periods where it might even be worse. So you would definitely want to do some kind of monitoring, whether it's a Holter, a Zio, a Barty, something to assess it. And let's say you do that monitor and the patient does not have anything other than occasional Mobitz 1 while asleep, which we've discussed is a normal finding in most patients. So how would you then, so you've ruled out all the bad stuff. At this point, you have to call this idiopathic, which is actually the most common cause of this, meaning we don't know. So how would you discharge this patient from cardiology? Would you continue to monitor this patient in cardiology? What would you tell the parents is the likely natural history of this?
Well, he did present with chest pain, right? So,
Right. But you've sort of, you sort of think that that was probably unrelated, right? Because you were able to reproduce it by pressing on the patient's sternum, and the patient says, "Oh, that's exactly what I'm feeling."
Right. So with a heart block, basically, we have to decide whether this patient needs a pacemaker or not. But I believe with a first degree block, this is not enough of an indication to have a
That is
pacemaker.
absolutely correct. And in fact, just to let everybody know, just this past Wednesday came out the newest, for the first time in over 10 years, pediatric pacing recommendations from the Heart Rhythm Society, in a co-branded with the PACES organization and ACC and AHA, and new recommendations. And first degree heart block is not a first or not a type 1 or type 2 indication. Nobody would pace somebody for first degree heart block. But would you monitor this patient? Or so the patient, the chest pain resolves, you see them back for follow-up 2 weeks later, you gave them some ibuprofen for the costochondritis, it resolved, patient's feeling well, EKG still looks like this, you now have all of your tests back, everything basically came back okay, you don't have anything higher, really higher grade than first degree. Does this patient warrant continued follow-up in cardiology, or can you discharge a patient from cardiology?
I think we can discharge the patient from the cardiology, except that I would want to follow up initially, probably more often. But then if the PR stays stable, I guess.
So you're sort of hedging, Dr. Babia, because you're saying, I think they can be discharged, but I'd like to follow them up. I think you're right. The patient should be followed up because we don't really have a good explanation for why the patient has first degree heart block, which means that it could progress. We just don't know why. Because we don't know why the patient has it, we do not know what the natural history of this is going to be. I think it's probably reasonable to surmise that over the course of the child's life, it will probably progress, because it is normal for all people's PR interval to get a little longer as you get older. But the question is it ever going to get long enough that it would require pacing? One option would be to do a stress test to sort of see what happens to the PR when the patient exercises. It can shorten, sometimes under adrenergic tone. This could be like a patient who has dual AV node physiology, for example, but it is a little unusual to have such a long PR interval. So you would generally, with someone with first degree heart block, my general recommendation is that they are continued to be followed. May not require very close follow-up. After you've done 1 or 2 Holters, you might feel comfortable that if it's progressing extremely slowly, in which case you might want to see this patient every 2 or 3 years. But I think in the absence of symptoms, at least every 2 or 3 years. And you would continue to follow this. I often tell the story of I once met a patient who had an EKG that looked just like this when she was about 12. And I did a stress test, and her PR would shorten up to about 190 with exertion. And she was completely asymptomatic. And every year I saw her, her PR was ever so slightly longer, but always conducted 1-to-1. And it was always just first degree heart block. Didn't even have Mobitz 1 on any monitor. And then one day she came to the ER after a syncopal episode, and she was in complete heart block when she was about 18 or 19 years old. And we put a pacemaker in. And we never really had a good explanation for why she had first degree block or why it was progressing. Perhaps in the future we'll have better genetic assessment of patients like this, and there may be a very good reason to explain this idiopathic diagnosis. But I think the bottom line is, when you see things in medicine that you do not have a good explanation for, it's probably a reasonable thing to continue to monitor them, because we don't know what the natural history of this is going to be. Okay. This is a Zio recording that I was reviewing recently, and I was just wondering if you think there is anything that is abnormal appearing on this tracing. I'm going to ask Dr. Perna Bonsall, who is probably very fatigued after a long weekend on call.
Good morning, Dr. Pass.
Dr.
What is the age of this patient?
That's a good question. This patient is 22 years old.
Okay. Um, it looks like, I mean, I can't say if it is definitely sinus because I don't have the leads, but from appropriately appearing PQRS morphology,
Very good answer. I like that.
it looks like sinus bradycardia to me.
I like that answer also. And you're basing that on the heart rate of 57, with 60 generally being the line in the sand. Okay.
Mhm. And since you're not saying anything else, I think there is something here.
Maybe you are correct to question whether I might show you a normal tracing and try to fool you into saying something that isn't there. But I would say there is still one other abnormal finding. But the sinus bradycardia will give you full credit for that, or at least partial credit. But is there any other abnormal finding on this tracing?
I don't see anything obvious jumping at me.
So what do you think about the QT interval on this tracing?
Oh, I did calculate that. Q 1, 2, 3, 10, 30. So it is, I think it's going to come out in increase because I'm getting a QT of 520, and then if I have to correct it for QTC.
Right. So generally, when you're correcting, right, if the heart rate is 60,
Mhm.
the measured QT generally equals the corrected QT. Okay. And if the heart rate is less than 60, usually it corrects shorter. And if it's faster than 60, it corrects longer. So this QT, that's a good general rule of thumb. So this QT is long. It's about 480 to 500 milliseconds. So this patient actually was having this ZO recording because of diagnosis of long QT syndrome. Now, why would we be doing Holters on a patient with long QT syndrome? So first of all, what would be the most common treatment we would use, Perna, for the treatment of long QT?
Nadolol.
Right, so beta blockade. So either
Beta blocker.
propranolol or nadolol are the two most common agents that have been demonstrated to be definitively associated with a reduction in mortality in all forms of long QT, with the possible exception of long QT type 3, although most authorities think long QT type 3, which you remember is a sodium channelopathy, is generally, most people would use beta blockade in that case, particularly propranolol, because it actually has some sodium channel blocking effects. But so the fact that the heart rate is less than 60 is a nice thing because it gives you a sense that the patient is taking their nadolol, right? Also notice the time of day, it's 1 p.m. in the afternoon, so that's good. So why would you monitor a patient with long QT with some kind of a Holter type device like this? I will tell you, this is a long-time patient who was well known to the physician as having long QT syndrome. So why would they be doing a monitor of this nature?
If there is like any occult arrhythmia happening, specifically torsade.
Right, you would certainly want to sort of surveil for torsade. You would also want to surveil for what's referred to as T-wave alternans, where you see from beat to beat a change in the T-wave morphology, which is often a sign that precedes torsade. And then finally, and perhaps most importantly, you want to see how well beta blocked a patient is. You want to look at their heart rate trend. I don't remember if I, yes, this is long QT syndrome, right? So this is the patient's heart rate trend from that same monitor. And as you can see, the heart rate, the vast majority of the time is between 50 and 100 beats per minute over a 3-day period. And that is a very good indirect sign that the patient is adequately beta blocked. This patient happens to be on a lot of Nadolol. I think is taking like 40 BID when I looked it up. But this is a good, now sometimes we make the error in thinking, where a lot of people believe that the slow heart rate of beta blockers is what is actually protecting patients with long QT. That is actually not true. The bradycardia that we see with beta blockers is a side effect of beta blockers. It is not, in fact, the effect that is causing the patient's risk to be lower. But we use that side effect of a slow heart rate as a good indirect marker that the patient is adequately beta blocked. And so, although you're right that we are surveilling for occult arrhythmia that the patient may not be aware of, the other important reason we're doing this is to make sure that the patient is adequately beta blocked. And this is a very, we would sometimes refer to this type of heart rate variability as very monotonous. And it certainly is not a normal circadian variability, because it's kind of the same all the time, always on the slow side. But this would be, I think, to most electrophysiologists and cardiologists, a reassuring trend in somebody in whom you are beta blocking for the treatment of long QT syndrome. Are there any questions about this?
So what is the beta blocker effect that's actually lowering the risk?
The beta blocker effect is essentially to affect the effect of adrenergic tone on the myocytes, which depending upon the channelopathy have different effects on the channel abnormalities. And perhaps one day we can go over all of the various different channelopathies. I think we should, and what the mechanism of disease is, and why it is that beta blockers are helpful. But it really is the direct effect of the enhanced adrenergic tone on the channels themselves that enhances the risk for serious arrhythmia. And in fact, there are some patients with long QT syndrome who, although very well controlled, are so bradycardic on their beta blockers that they might in fact even need pacemaker. And when in those rare long QT patients in whom we place a defibrillator, and there are specific reasons or rationales to do that in some long QT patients, most of the time we would put a dual chamber device in order to maintain a normal heart rate. So I have a handful of long QT patients, for example, who have dual chamber defibrillators, but they're being paced in the atrium, maybe at a rate of 60 or 70 during the day, because their heart rates are sitting in the 30s and 40s, and they suffer from chronotropic incompetence and just being very tired. But pacing the atrium does not enhance their risk for arrhythmia. Any other questions? Okay, I think with that, we'll stop for the day. Thanks for joining, and I hope everybody has a great day and a great week ahead.
Thank you, Dr.
Thank you.
Thank you very much.